Mike is the governor wherever he goes. And he attracts everyone, and everyone just is drawn to him. He is incredibly smart. He is incredibly funny, quick.
Prior to me meeting Mike, there were some things in my life that were quite sad. I lost my son in an automobile accident, and I met Mike, and it was all about jokes and goofing around and having a good time and always a positive attitude, and that in itself really captured my heart. We became friends, and then it developed into a relationship. Got engaged after, I think it was the 11th or 12th time he asked me to marry him. And then from there we got married, and the rest is history.
When we got the call, it was for a overturned vehicle on the interstate, and it was right off the exit right next to our station. So it was really close by, didn't have a whole lot of prep time. When we got on scene, saw the vehicle on its roof, and when I approached the vehicle, the only thing I could see was a little bit of the back of the patient's head. The probability of him having a traumatic brain injury was pretty high, and as I couldn't access him to do a thorough assessment, the decision was made to go ahead and call for a helicopter to get him to VCU as quickly as possible.
Got everything needed, like the stretcher, the backboards, and the seat collars, while the squad crew was getting the whole car stabilized, doing their things, like sometimes needing to cut doors, sometimes making sure the car won't move anywhere. With the whole process after they got the car stabilized, it was actually one of the firefighters, Rowley, that she went into the car to try to get access to the patient. So she was the one that was able to get a seat collar on the patient's neck first. And then after that, she was kind of like able to maneuver the patient to the point where we were able to kind of grab him and be able to put him onto a board.
We could tell he was in trouble. He was bleeding from both ears, so the probability of a traumatic brain injury is really high in that case. His initial presentation, he was very hypotensive. I believe his systolic blood pressure was in the 70s. Seeing that his blood pressure was already plummeting, we knew that he was in bad shape, and we desperately needed to get something done.
So when we land, we carry all of our gear over to the ambulance. When we first arrived, he was unconscious on the backboard. EMS had started an IV for us, which was amazing, and he was strapped to the backboard really well.
And this guy was not doing well at all. The first thing that we need to do is we need to get his blood pressure up, because we can't give medications to facilitate intubation until we have a blood pressure, because if we give those medications, the blood pressure just gets worse.
With that, we got ahead and started our whole blood. We carry whole blood, and we started that immediately on a pressure bag to try to get his pressure up.
Then I placed the airway. I did the airway. We've done all that we can do in the back of an ambulance. We've got to start moving towards the trauma center. Once we get closed up and we tell the pilot that we're ready to go, the very first thing that we do is I'm ventilating the patient by a bag valve mask, and so we want to get them onto the ventilator as quickly as possible. So that's the first thing that she does. The blood pressure was still low, so we had to hang the second unit of blood.
We gave some medication en route also to make sure that he was pain-free and still sedated underneath all the paralytics that he was given for that intubation, so to ensure that he was comfortable.
We get the things done that we need to get done immediately, then we'll call VCU Communications and give them a rundown, give them a patient report.
We had stabilized him pretty well actually for his blood pressure, so we went ahead and did a cold offload where we shut down, and then one of the techs from the VCU ER brings us a stretcher with some oxygen and helps us offload him, then get in the elevator and head down to the ER.
I didn't understand why I was getting phone calls from area code 804, but then I realized, oh, it's probably his boss. So With one of those phone calls, I answered the phone and it was his boss, and he said, "Hey, is Mike home?" "No." "Well, we are not sure where he is right now." "Well, I have a feeling that I need to get dressed, get done. Something's not quite right." When the phone kept on ringing, and one of the phone calls was his boss calling back, and he said, Mike's not here. So then I looked on my phone of all the other 804 area codes and figured out, wow, somebody else is trying to reach me. So I called that number, and it was the hospital. I learned that he was in a car crash, so I got in the car, traveled to VCU.
As I recall, his injuries were concentrated around the head, neck, and torso. He had multiple rib fractures, pulmonary contusions. He had a bleed inside of his head from blunt trauma. He also had some orthopedic injuries, I think clavicle fracture. So these are pretty severe injuries. He was in hemorrhagic shock. He was resuscitated.
I had worked to stabilize him in the emergency department, and then we had a shift handoff. And I remembered looking at his CT results kind of later in the day after I'd woken up, and just reading the extensive amount of polytrauma that he had, did make his situation seemed pretty grim.
I was with him in the operating room twice. The first time was to explore his belly because he had the fluid in his belly, and even though his blood pressure had improved and we put him through the CT scanner, we were concerned that he may have a bowel injury, and that's hard to fully assess on a CT scan. And so when you have a patient who is not doing well, they've had a big trauma, some of the safest things to do are to just explore and rule out anything that can be life-threatening. We ended up taking out his spleen and part of his pancreas because there was blood in the area where those organs sit. He had a small tear of the colon that we could easily patch up, but we ruled out life-threatening injury that was inside his belly by doing that.
I could tell you that evening, there was a lot to try to process. My sister-in-law, Nan, had arrived.
What I remember most is going into the room that Mike had all these tubes and the intubation, and his poor face was swollen from all the lacerations. And he was unrecognizable as my brother.
It was clear that there was going to be a lot that we kind of had to talk through in order to get a full grasp on what was going on with Michael and kind of what his, what the next months would look like for him and not just the next days.
I was not that concerned about his brain injury. My main concern was his paralysis, which I could tell was not coming from the brain injury. And so that was the ongoing concern until we had our MRI scan. Once we had the MRI scan, we had the answer. What had happened was the soft tissues of the spine had been disrupted. So it did not leave any fracture that we could see on the CT scan, but it had been enough that it had injured his spinal cord so that he wasn't moving his legs. And then finally, Dr. Shaw from orthopedics performed surgery to stabilize the spine.
He had a wrist fracture that was treated non-operatively in a cast. And he had a clavicle fracture that we treated with open reduction internal fixation, so plates and screws. To address his cervical spine ligamentous injury, he had an ACDF, so we actually go through the front of the neck and we'll put a small plate on to stabilize the area that had the ligamentous injury.
Whatever force went into him cracked his sternum in half right along this way and broke the ribs on both sides. My partner had already fixed the right-sided ribs, but this time it was at the same time he had his cervical spine fixed.
So it was putting the ribs back in their original spot and plating them the way they're supposed to be so that he can breathe normally and comfortably.
So when I got involved in his care, we were working on trying to get him off the ventilator, but unfortunately, it was very challenging to do so with his mental status being where it was and likely wasn't safe. And as much as we wanted to advance his care, we were at a time where we couldn't really move forward without that. We were there at a time to kind of walk them through the next steps of getting them through getting a tracheostomy, which is challenging for patients and families, but it's going to be really important in advancing their care as it was for Michael.
During that period of time, Michael had the first set of surgeries done, and then we were given the list of all his injuries.
But what I remember the most was having all the issues with breathing. That's why he couldn't stay off the bed and needed optimally a trach. Because in pneumonia, a lot of the issue with this kind of patients, especially with Michael not being able to do everything we need to do to keep him off the bed, is if you take a deep breath with so many broken ribs and having chest tubes and all this stuff, it hurts. So they just try not to breathe. This is a normal progress for a lot of these patients that are so sick. They happen way after they come in, so family number get like, oh, this is a setback, things are going wrong. This was already an expectation. This was gonna happen. He's on the right place. We're gonna take care of him.
Hey, Mike. Oh,
there you go, there's Carolyn.
Watching the team at VCU, we felt really confident that we had a village to support us and that everyone was really vested. So I really didn't think that we were gonna lose my brother. I watched the skill sets of the team there, that if we do this, this is gonna happen. This is a side effect of this. But so we have to really strike balances all the way through every procedure and everything that we look at. Okay, he has pneumonia, but we can't do this because it'll affect that. And there was, just a collaboration of everyone to really make sure that the best possible action was taken for any event that was going on with Mike.
Our job was to sort of wean him off the ventilator, which took a long time, and with multiple rib fractures both sides, it was very difficult to get him weaned initially, and of course the trach helped that process.
For us too, we were looking at, what are the next steps that we can move him forward safely to really work on that, get him to a place where we can see how he's doing cognitively, because with the diffuse axonal injury, those can be really devastating at times, and we always want to give people the best chance to recover from that and get through their acute medical problems as quickly as possible to begin that long road to recovery from the neurological standpoint.
We give people spontaneous breathing trials where they breathe on their own. We totally take the vent off. It can be a scary time for people, but and at first we sort of had to talk Dawn Marie into this is the natural process, and it's a scary time, as I said, and it's scary for the patients and the family, but they embraced it, they took it on, and when he started to do better and better with that, I saw the excitement in the family, excitement of Dawn Marie. When we'd come in the morning, she'd say he did 8 hours yesterday, or he did 12 hours the day before, or something like that, and those were real milestones to show he was improving dramatically to try and get him off the ventilator.
I think when Dr. Wayland came in after different tests were done about Michael's brain injuries, there was a question of whether or not Mike would be able to lead a normal life. And said, Dawn Marie? And he went like this, he goes, it's gonna be okay. And I said, truly? He said, yes. And I said, it's just remarkable. I said, everything you've done, that you've had your hand on has just been awesome. And he said, it's not me, it's my staff. And I said, you're being humble because it starts at the top.
The first day that I saw him from a PT perspective, he didn't have a lot of strength on his left lower side, but otherwise he was showing good muscle activation. He didn't have any limitations that would prevent him from being able to progress to being ambulatory. So I knew that he would be a great candidate to really work intensively with physical therapy during his hospital stay.
One of Michael's main injuries was a traumatic brain injury. So when he came to us, we were really working on making sure that he would be able to go to his rehab facility. So we had to make sure he could do 3 hours of physical therapy a day. We had to make sure he had a speech language pathology consult. He was able to swallow and work on his speech on his own. And working with those interdisciplinary teams is really important to get people off our floor into the rehab center they need to go to.
With his TBI, in terms of OT, it really can affect kind of your ability to kind of sequence dressing, like putting on your shirt backwards or forgetting that you need to have 2 socks and some pants and some underwear. I remember one time we went to go and make a bed because he was really working on balance and those kinds of things. Those tight turn navigations were really hard for him. So like every time he would do kind of a tight turn, he would lose balance, and I was giving him maybe anywhere from like 25 to 50% to help rewrite him. A lot of times I think the memory and the recall was really hard for him, but I mean, we accomplished it. We had some losses of balance, but he came through on the other side.
Michael came to us after a motor vehicle crash. He initially went to the trauma center at VCU, and when he was medically stable, he came to us. When he first came to us, he still needed assistance for walking and transfers and mobility. His balance was very compromised. He was actually very high risk for falls when he came to us.
As he progressed during his stay, he started to get more independent with his self-care tasks, so we started to work on kind of higher level activities such as home maintenance. At one point we were able to take him out into the community.
We had to make it very salient for him. He liked the outdoors, so we spent a great deal of time outside. You know, whether it was walking through the woods or walking in sidewalks, on the grass, on slopes, and mobility, even engaging in activities such as basketball with a therapeutic recreation.
And he was very motivated to get home and be with his wife. Being able to bump up his discharge a few days was really exciting for him and a goal that he had.
When Michael first arrived, it wasn't at all sure that he was going to make it. Things were not, this was not going to be an easy road for him and his family. So to see everybody come together and see how everything came together in the end is the most gratifying thing for me, and it's why I do the job I do now.
Here was this guy who was active and independent and going to the gym every day, and he had great family support and had a very cognitively challenging job. So he had all of the prognostic factors to lead us to believe that he would make a good recovery. But I think it's at the end of the day really his determination and his excellent family support that really helped carry him through this terrible time in his life.
So I mean, every day when I leave work, it's an incredible honor to be a part of this team and to be training somewhere that has such high acuity as VCU.
VCU is among the best of the facilities I've ever witnessed in my life. I feel as though we couldn't have been in a better place in the United States, truly.
There are no words to express my true feelings, our whole family's true feelings, on knowing what you did, your dedication, all the years of training, everything that you do. It's selfless. You gave us a chance to have a life that we didn't think possible. He's now here to see his grandchildren. He's here to be with his family, to go out with friends, to do things. He's back to work. And no one thought that was going to be possible.